Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dull Simons Family Studio. We're back, and we're delighted to be here with you today. Welcome to another news and community conference with the Chief Medical Officers and infectious disease physicians across the metro and across the state of Kansas. This is a great program. These are good people. We are blessed in our area, both Kansas and in the Kansas City metro, to be working with these terrific folks, and they're delighted to have them back on the program today. Hey, since last week when we were together, COVID cases are starting to decrease. That is great news. Man, I tell you what, I go home at night, I'm like, oh God, the counts are down a little bit. This is the best. The bad news is they're still at the highest levels of the pandemic. And even worse, they're an average of 4 deaths from COVID every day in the metro and in the region. 4 deaths per day. That's making this one of the highest causes of death we all have to deal with. ICU capacity is still strained because COVID patients, who often stay much longer than other patients, up to 3 times longer, and all this according to the Mid-America Regional Council surveillance. Folks, here's the story. We are COVID better. We are most certainly not COVID good, and we are clearly not COVID free. So COVID better does not equal COVID good. Over the next 45 minutes, we're going to hear from the chief medical officers, including myself, with specifics on how the entire healthcare system remains under great stress due to the sustained period of high transmission within the community and the depletion of our workforces, not only in medicine, but throughout everything. We ordered a piece of furniture because we worked on, we downsized, moved into a condominium. This is all great. Had to get some new furniture, ordered some furniture. A year later, we don't have that furniture. And it's because of the same problems we're facing throughout the supply chain in America. This is a challenge to all of us. And the only way we can make sure we get out of it is to be COVID good. That's where we need to strive for. After we hear from physicians, we'll open this up to reporters and the community for questions. We ask the reporters to please remember to say your name, the name of the news organization that you're asking questions from. Members of the community should put their questions into the chat feeds where we'll be watching. Jessica Lavelle will be monitoring those feeds for questions, and we've asked the stations who are restreaming this to monitor their chats to share their viewer questions as well. Let's begin. We're going to start with Dr. Watson. This is where we are according to this morning, according to graphics in the New York Times and the Mid-America Regional Council. We'll bring in Richard Watson, who's a co-founder of Motion, the company which created the Mission Control app that the Kansas Department of Health and Environment uses to connect rural hospitals when trying to transfer patients. Dr. Watson, we know we only have you till 8:30. We understand that things are beginning to look a little less congested. Show us what you're seeing.
Yeah, thanks again for having us this morning, and really appreciate the time. I think it's exactly right. I think we're all feeling that the downturn has started, but I think overall we know that the job is still tough. So if we could go to the graphic, I'll show you the curve on the upper left, one we're used to, continued downtrend in transfer volume related to the COVID cases. And again, this is a continued steady downtrend. The one on the right is the one I want to focus on today. That's the heat map over time of capacity. If there were other colors on here, green would mean normal capacity and yellow would mean limited capacity. Red means no capacity. And as we tracked across the weeks through November and December, you can see the burden everyone's been under. It's been a tough go all the way across. If you could just decipher the very far right where the color change is starting to move to an orange. 3 is no capacity. We've been at 2.9 for almost 3 months. We are now running in the 2.7 to 2.8, starting to see some 2.6, 2.7. We really have to be below 2.5 for anyone to feel more relaxed. I know there was a moment where the volume was going down. Immediately, some of the receiving hospitals opened up. We literally cleared the board for a short period of time, just moving patients to big receiving hospitals. And I think immediately then all those beds were full again. Capacity went to about 0 again. And while the actual number of patients waiting dropped significantly, again, we just reloaded the system. It's going to take 2 to 3 weeks to clean that out again. I was on a call yesterday with smaller hospitals, and they're really still feeling the pressure across the board. It is easing on some fronts, but overall, no one is feeling like we're anywhere out of the woods on this at this point.
So COVID better, not COVID good. And to your point, we're still not really to the situation where we can take patients in from other hospitals who need our help on a regular, reliable basis without some sort of a time delay. Is that a fair statement, Dr. Watson?
Yeah, while we're still at the 2.7, 2.8 range, that means patients are waiting 10 plus hours for transport. And that's as opposed to what we usually see. If it were normal capacity, it would be 1 to 2 hours, with time critical diseases being less than an hour to move patients out. So this is an unbelievably exceptional moment we have. And while there is good trend all across the board, we don't think that this is letting up this week, next week, probably the week after. 3 weeks out, we're looking at a time where we're really able to see something completely different.
Yeah, I think, it's an interesting question. What happens to a patient in the 10 hours that they can't get the care they need? And this is not just COVID patients. This is every patient who needs to be transferred. What goes on in those 10 hours? We know that our hospitals in the small towns are doing the very best they possibly can to try and help as much as they can. But if they could do everything for that patient, they wouldn't need to transfer them. And so there is some difference in the standard of care. And to your earlier discussions on this program, you've seen an increased death rate in people waiting in the emergency room too.
Yeah, and we know that's directly related to how long people wait in the emergency room. And I do think it has been a huge burden to small town hospitals with fewer resources to take care of these exceptionally ill patients. Fortunately, a lot of you all, the receiving hospitals, have come alongside and offered to help care in place. We've enlisted some outside sources to help with telemedicine care while people wait. I think the medical community as a whole has really come together to help each other out in this time, to realize that this is a moment where we all have to be on the same side. We all have to work for the same goal. And we've done some exceptional things along the way. I hope in the coming weeks, as we kind of do a post-hoc look at this, that those are the things we focus on, the good things that came out of the system during the tough times that we want to take forward, that we want to carry into the next period. Don't for an instant think that we're not going to have some sort of surge in the spring, that this is going to have a little seasonal reoccurrence. We don't know what that looks like. Obviously, we hope it's less, but we need to not try to reinvent all these things we've built over the last several months to try to accommodate what the resources in the system are lacking right now.
Yeah, and I think that's a great point. And telemedicine can really help in a lot of cases unless you need an intervention. If it's the intervention you need, that's often harder to do on a teleprompter. So, all right, well, we're going to get into our discussion around the numbers this morning. Dr. Raghu Adiga, who's a chief medical officer and a stalwart on this program, is from Liberty Hospital, an infectious disease doc. He couldn't be here this morning. They're having a joint committee visit. So he sent their numbers. Liberty Hospital has 24 COVID positive patients, down from 32 last week and 44 the week before, which I believe is around their high. So certainly getting better, but not good. They have 5 COVID patients in the ICU, 3 on ventilators. They've had fewer COVID deaths so far in February, down from a record high in January. However, the Northland incidence of COVID in both Clay and Platte counties is really, really high. Let's turn to the chief officer at Advent Health and Advent Health Shawnee Mission, Dr. Lisa Hayes, an outstanding endocrinologist there. Lisa, how are things at Advent?
Good morning, Dr. Stites. I have to say things are improving here at Advent Health. We are seeing a downward trend continue in our COVID numbers. Yesterday, we had 33 active infections and 17 that had cleared their infection. We're down approximately 41% from our peak in January. So that's a nice downward trend of patient numbers. And we're seeing fewer people in the intensive care unit as well. I'm sad to report that we did experience 5 deaths already in February from COVID. And so people are still passing away from COVID. It's sad to report that. Our ER holding times have decreased dramatically. We're having less patients waiting in the ER, which is nice. In January, we had 186 transfers that we had to decline because of not having availability. And I looked at that list today, some as far away as Oklahoma and St. Louis. So quite a broad effect. We're still having employees out with COVID. Yesterday, we had 48 employees that were out with COVID. That's a nice downward trend, but we're still continuing to see staffing shortages. 37 of those 48 were in a clinical setting. So people not available to be at the bedside to help care for patients. We have been able to open up our elective surgeries. We haven't had to cut any more elective surgeries, which we're happy to report as well. So things are improving. They're still not there. I was laughing to myself when you were talking about supply chain issues. My favorite supply chain issue from our month of January was when we were running low on styrofoam cups for our patients. We didn't get the shipment we needed. And so our emergency management manager had to do a Costco run and buy up as many styrofoam cups as he could. So yes, it affects.
You got to keep coffee in people. So now let's see. You've been in the CMO there. How long ago did Dr. Botts retire? Has it been 6 months, 8 months? How long has it been now?
A good 7 months.
Yeah. So how's it been? Because this is like brand new in a pandemic, Dr. Hayes. This had to be what heck of a. Is this what you signed up for?
It has been an adventure. And I'm excited to see what happens when our COVID numbers continue to decline and I get to do everything else the CMO is supposed to do.
That we will all welcome that for sure. Thank you. Dr. Elizabeth Long, Chief Medical Officer of Olathe Health, also could not be with us today. Wanted to share these numbers: 17 COVID positive patients, 6 recovering, 6 in the ICU, 1 in the vent, 9 employees out with COVID, also down from them. I believe Olathe peaked up in the 40s as well, so COVID better. Dr. James Stewart, Chief Medical Officer at North Kansas City Hospital. How are things up in the Northland?
Good morning. We're seeing a positive trend as well. Today we have 54 patients in the acute phase with 40 that are recovering for a total of 94. And for perspective, we peaked in mid-January at 145. Last week we were kind of plateaued at around 120, and now we're under 100 for the first time in several weeks. So that's certainly a positive trend. We did set a record in January with deaths at 65, which is averaging a little over 2 a day. So far in February, we've had 11 deaths, which is averaging just over 1 a day. So that trend is better as well. You mentioned that the numbers are still high in Clay County. The week ending January 29th, there were 637 per 100,000, which is a lot, but that is down from the week ending in January 15th, where there was 1,178 per 100,000, which is really high. So it's getting better.
It is really high. It is getting better. Man, it is not good yet. And Jim, do you remember how many COVID patients did you have in February of 2020?
It was around 100.
Yeah.
But we're still at the peak.
I'm thinking 2020, not 2021, man. How many did you have in 2020?
In January?
Yeah, of 2020, February? 2020. Oh. I'm thinking the number was 0. Yeah, exactly. And I think, sometimes we remember it. We're COVID better. We're not COVID good because we used to have 0 COVID patients, and yet we were all still pretty full. And it strikes me as what happened to all those folks who aren't here right now. Dr. Mark Steele is the Executive Chief Clinical Officer at University Health. Mark, how are your numbers this morning?
Hey, good morning, everyone. We continue to see improvement in our numbers like everyone else. We have a total of 91 patients in our hospitals currently. 37 of the 91 have active infections and 54 are recovering. Our active infection peak was 109 on January the 19th, so we've actually seen about a 65% improvement. 7 of the patients currently are in the ICU and 2 are on ventilators. Like the others, we had our high in terms of deaths in January at 36 compared to 22 in August. Unfortunately, we've already had 6 deaths so far this month. We certainly remain quite busy. We're holding 8 patients in our emergency department this morning, pending admission. Good news is that our employees currently out related to COVID continue to decrease. Another piece of good news is that our test positivity rate continues to drop dramatically. We actually are currently at 13%, which is much improved from the nearly 40% we were at the peak of this Omicron wave. These, of course, are all encouraging improvements, but as Dr. Stites, as you said, when we look at the regional data, cases remain well above the prior peaks we saw last winter and during the Delta surge at the end of this past summer and early fall. And hospitalizations are right at those prior peaks. So we still have quite a ways to go to reach the lows of last spring and early summer, which is where we would all certainly like to be.
Man, yes, I want to bless that, because last March I think we got down to 5 patients here, and that's a far cry from where we are today. We're going to call that COVID good. We're not a COVID good. All right, so let's turn to Dr. Ahmad Batrash, who's Chief of Staff at the VA Hospital in Kansas City. Ahmad, how are your COVID counts today?
Looking better like everyone else. We are down to 17 total. 2 of them cleared their infection with 15 with active infection. Of these, 5 are still in the ICU and 10 on med surge, and 1 of these are on the vent. This is a reduction of like 50% from last week, actually, and about 56% from our peak, which was 2 weeks ago. The outpatient numbers are also decreasing, which is really good. We are down to 212 active infections now on the outpatient side, which is down from 650 peak. So that's about 68% reduction from mid-January or so when we peaked then. We did lose 2 veterans to COVID this week. So that's 2 deaths this week. So still people are dying from COVID, so it's not a benign disease, and it's not like as you said, oh my cold. No, it's not the case at all. And as far as the test positivity rate, also decreased quite a bit from 31% in January to about 20% in February so far, and it continues to decrease week to week. So that's all good signs. As far as bed status, we are really gridlocked for beds. We have no beds today available. All beds are full. We are boarding patients in the ED. Like there's at least 4 this morning when I checked, waiting for beds in the emergency department. So that's really not a great situation, and we would like our capacity to be much better than this, obviously.
Yeah, I thank you. And thanks to Dr. Batrash for the great work you do. I've known Dr. Batrash for a very long time. I know what a great person he is. The veterans there are under great care with him. And I've known him since he was a young guy over at the VA and became an associate program director in our residency training program. So, Ahmad, thank you for being with us again today. Dr. Jennifer Scrimshire is an infectious disease physician at LMH Health and the Deputy Public Health Officer of Douglas County. I'm not sure which job gives her more heartburn right now. She'll have to tell us that. What numbers do you have to share with us this morning, Dr. Scrimshire?
Thanks, Stites. We currently have 23 patients total, 15 active, 8 recovering, 4 of those in the ICU, 3 on vents, and that vent number is higher than our typical. As a comparison, I think in November we had 1 patient. So still our numbers are still high. We lag a bit behind Kansas City usually. We're down from 80 employees out to about 30, which is great news. For the county, we're down to about 150 new cases per day compared to our previous peak a year ago or so of around 80 cases per day. So we're still about double what we were. Positivity is coming down, but we still have around 4,000 active cases in the county, which is also extremely high for us. Well, I don't know about our deaths this month. I haven't looked at that yet. But just as a reminder, at one point, the U.S. saw about 4,000 deaths a day in one day. So I don't know. Again, a reminder that oh my cold, that's what Stites likes to call it, is not. So we're still seeing the effects. I think we're trying to find some way back to some semblance of normal, trying to recover a bit at the moment.
So, Dr. Scrimshire, should everybody just take their masks off right now? I mean, are we so good that we can take our masks off and go inside and have a big party?
No. Short answer is no. Like I said, we still have 23 COVID patients, which is high for us. So we're still at 90% capacity in the ICU. We don't have much. There's not a lot of wiggle room to deal with another influx in cases at the moment.
Yeah, and I think that's the message. COVID better, not COVID good, right? So Dr. Jackie Hyland, who is the Chief Medical Officer at the University of Kansas Health System in St. Francis and has to put up with me more than she'd like, what is your patient count? How are things at St. Francis today, Jackie?
Good morning. Good morning. And you're very fun to put up with, Dr. Seitz. So it's a pleasure to be here and to be able to see all these amazing faces. We are COVID better, not COVID good. So our high was I think it was 42 at the beginning of last week, end of the previous week before that. Today we are at 23 positive, 6 are recovered, 4 are in the ICU, 16 on medical. An interesting number that we're seeing is the percent hospitalized that are unvaccinated. So today it's below 50%, so 46.7%. So that was surprising to me. I don't think that means that people should not be vaccinated. I think people need to get boosted. Our positivity rate is hovering around 20%. It's gone up from 19 to 22 over the last several days. We have seen a lot of deaths here at St. Francis. In January, we saw 32 deaths. I mentioned last week that our average number of deaths pre-COVID was about 12 to 14 per month. So it's a significant change and really hard on family, the community, and staff. In February, we have seen 7 deaths already. So even though the case numbers are going down, I think the hospitals continue to, handle some of the most difficult aspects of the pandemic. And I just want to say thank you to Dr. Watson. I think he has jumped off, but I think he highlighted one of the good things that have come out of the pandemic. And I think it's everybody coming together to figure this out. I think healthcare needs a lot of help and support. I think everybody coming together within healthcare, but I think our communities also really need to join in the healing of communities, the state, and the nation. So.
Yeah, no, I think that's well said and exactly true. I'm also, as we hear this story of death, clearly not COVID good because the United States is continuing its inexorable march on toward 1 million people lost from COVID. That's a 1 million man march that we did not want to be a part of. Dr. Kevin Dishman is the Chief Medical Officer at Stormont Vale Health in Topeka. Kevin, you've been just as straightforward and honest, and so appreciate you being on back with us today and the great work you're doing in Topeka. Tell us what's going on at Stormont Vale today.
Thank you, Dr. Stites, and thanks for allowing me to be with you today. I could echo many of the things that Dr. Hyland said. We're seeing the same thing. I think the important news from the region is that we are still seeing quite a high number of transfers for COVID. Working closely, as Dr. Hyland mentioned, with Dr. Watson and his team, we continue to have a very high census. Our census actually went up today. We have 70 patients, over 20 of those are in the ICU, many of them ventilated. And we're seeing that because of transfers from the region. And so the test positivity rate here in the region remains at 30%. So we are still in the midst of this and still continuing to utilize resources. One of the things that we're seeing is, as Dr. Watson mentioned, that many of these patients are being cared for where they are. And our regional physicians, our rural physicians are doing an outstanding job of that. The intensity of the patient that we're seeing transferred to our facility has dramatically increased over the entire period of this pandemic, but even more so now as we're seeing people who are very, very ill from this disease and continue to see, as I said, a 30% test positivity rate in the region. So it is not gone from Kansas. It continues to be a serious issue. It continues to be a challenge. I thank all of you my colleagues for everything you've done to support our regional hospitals and take all the transfers you can. And we've really gotten to the point where everyone is focused on how do we take just one more, and then the next one. And that really supports our rural hospitals and our regional hospitals. So I want to thank all of you for all of that support and all that your teams and staffs and Dr. Watson's team are doing to get care to these patients.
Yeah, thank you. And I think ditto. And that's exactly right, because we are in this together, which I think is one of the best parts about the pandemic is the coming together of this group and other groups like it. We're working together, and even though we may be fiercely competitive on same fronts, man, we are all competitive against COVID in this front, and that is what's in this room.
Right.
Dr. Samir, you bet. Thank you. Dr. Samir Sam Antonio is the Chief Clinical Officer of Ascension Via Christi. Sam, you've had a battle in Wichita. Things have gone pretty high, and I've appreciated your stewardship there. How are things today?
Good morning, everybody. Good morning, Steve. So today at the system level, we're about, as of last night, we were 138 patients total. Now, 85% of those are actually in the Wichita market, but the rest are throughout our system because we serve many communities, as you're well aware. We've got 40 patients in the ICU, and we have 11 patients who are on a ventilator. Now, the total census, that's about, just to give some perspective, 20% improvement from last week. But when it comes to the ICU, that's only an improvement of about 8 to 9%. So as to your earlier point, even though the overall census is improving, the ICU is much slower to improve. Today also we have 4 pediatric cases, and one of the things that earlier on you commented about the deaths that are happening in the country, and they also were unfortunately reminded by some milestones of deaths that are happening within our own state. As I was looking at some of the dashboard in Sedgwick County, we're approaching a sad and somber milestone of 1,000 deaths. We're 970 something, so we're only a little bit away from 1,000 deaths. And then at the state level, I was also looking at some of the published numbers on KDHE site, and we're almost at 8,000. Again, another reminder that this has impacted a lot of people, a lot of families, and we need to continue the message and help people try to avoid unnecessary deaths. So things are improving, not where we want them to be yet, and more reminders that we're still in the pandemic.
Yeah, perfectly said. Thank you. And just to echo that, it's not only the death, the number of long haul patients has overwhelmed us, and I'm sure it's overwhelmed everybody. That's a whole class of people, a whole group of folks we're not talking a lot about yet, but we're going to be talking about for years to come, because there are a lot of people who are going to suffer, who are suffering for a very long time. And that is true with Omicron as well as the Delta, the original strain, the Alpha variant, all of the above. And that's a struggle, and it mostly and especially affects those who are unvaccinated, those with diabetes, those who are overweight. And so, unfortunately, there are a lot of Americans in that category. Dr. Robert Freelove, the Chief Medical Officer at Salina Regional Health Center. Dr. Freelove, and I got your name right. I'm going to get Dishman and Freelove straight today, I promise. I've been trying to rehearse the mnemonics for it. Dr. Freelove, how are things in Salina?
Well, in some ways we're better, and in some ways we've kind of plateaued, and other ways I think we're better, but it's hard to tell for sure. We're running 22 inpatients right now. We've kind of plateaued here over the last 2 weeks. We've been at our peak, we were averaging between 25 and 30, and now the last 2 weeks we've been averaging between 20 and 25. So it's a little better there, but we have plateaued here over the last 2 weeks. What I do know is better is the number of employees we have out ill. We peaked at 130 about two and a half weeks ago. We're down to 32 out total, 24 of those with COVID, which is a lot better than when we had 90 out with COVID. So that has allowed us to do some things like start doing elective outpatient surgeries again and opening up a little bit there. What I'm not sure is better is our case rate. It does seem better. It looks like we're seeing fewer positive cases here through our testing. The reason I say I'm not 100% sure is because that old supply chain problem. We've struggled with some of our PCR testing supply chain, and we've had to send more tests out to reference labs, and there's a lag there of 3 to 5 days to get some of those results back. So while it does look like our case rate has dropped some, it's hard to tell for sure because of that lag. So like I said, a little better in some ways and not in others. We have had 4 deaths so far in February, which, that's quite a few for no further than we are into the month.
Yeah, no, it is. It is definitely not COVID good, and this is the story is we're hearing it from Salina. Let's turn to Dr. James Alexander, Chief Medical Officer for Centura St. Catherine Hospital. All right, how is it?
Good morning, everyone. I think I'd like to give a bright spot. Our ICU is at 90% capacity. We have 9 inpatient COVID. Our positivity rate at this point is right at 25% in the community. We've had no transfers, and we don't have any ED holes at the present moment. Our death rate's down to 2 for the month from 13 back in January. Our associates out is also substantially down from what it was just a month ago. But what we are seeing are some readmissions of our COVID-related illnesses left over from our Delta patients. So we have those folks on BiPAP and heated high flow. 3 are on the ventilator. That's what we're seeing here in Kansas.
Well, thank you, and I appreciate the strong work you and your team are doing in Salina to help keep Kansas healthy, and it has been a battle throughout COVID. We go a little further west, we'll talk to Dr. Heather Harris, who's the medical director at Hayes Med. Dr. Harris, I know it's been hard out in Hayes, too.
Good morning. Yeah, our active numbers are seeing a slight improvement. Our actives are down to about 7, but we still have 18 recovered. I think that's sort of the take-home message is how long it takes to recover from this illness. It can be a very long hospitalization, and then obviously, as you mentioned earlier, months and months, if not years of complete recovery. Our staff is much improved. I think we only have a couple out. So that the community, I think numbers are improving. I also think there's probably some testing fatigue. So I never really know for sure if the numbers, I know they're better, but I know people are tired of testing too. So, but we're seeing the community's better. So hopefully the hospitalizations will improve. We continue to be closed intermittently through the week. ICU pretty routinely through the week. And even the hospitals continue to have struggle with capacity, just trying to serve the Western swing out here.
Yeah, that's a tough one, and so thank you guys for the great work you all are doing out there. All 3 of you are doing out there in central and western Kansas. And Hawkeye, our numbers are plateaued. They're lower. They are not good.
Yeah, they're definitely lower than they were, say, 7 to 10 days ago. Plateaued right now. Let's keep a running track of the 7 to 10 day rolling average. Hopefully it continues to go down. Right now we're at 75 active infections, 21 in the ICU, and 10 on the ventilator. We still have 99 in that recovery period, so a total of 174. But unfortunately, like we are hearing, we have continued to have deaths. We had 3 deaths on February 7th and 1 death over February 8th. And I think just to reflect and comment on your comments about long COVID and Dr. Antonios and our other guest comments on the deaths, to continue to say that this disease, and I mean coronavirus in general, is just a cold, continues to be myopic, misinformed, and really just not sensitive to the true nature of what is really going on, either because you just don't know and are ignorant, or you really don't want to believe what the truth is. But it does continue to hit us, and it's all variants, and all these variants we have seen have caused a lot of complications, whether severe complications such as death or those continued complications such as a long haul. So it continues to be with us. We have seen that recently, the deaths have gone up. This is not unexpected. Again, we know that the cases continue to surge and then they fall. And then later after that, we know that the hospitalizations start to decrease. But unfortunately, the last thing to follow with that is deaths, and I think that's what we're seeing right now.
Yeah, I think that's exactly right. It just goes on. And to your point, the normal coronavirus just doesn't cause many deaths at all. And this one is not the normal coronavirus. Yeah. That's all right. That's right. All right. Well, so let's unmute mics for the reporters on the line. Let's see if you have any questions out there. Share your name, news media organization. Are there any questions to reporters? Jess, I'm going to turn to you now. Jess, first of all, you have to give us an update. We know that Sunny was ill yesterday. Is she better? Things going to get okay in your household?
Well, she's better, but now my other one's sick. So we're ping-ponging it back and forth.
All right. Well, stay healthy out there. So.
Thank you for asking. Okay, so I do have some community questions. And the first one is, are you concerned about the BA2 with masks going away in Johnson County schools? You keep saying that spring will be good. Do you think another Omicron wave is coming with the new data? So lots of things in there. But first let's just talk about what spring's going to look like.
Yeah, we could do that. And let's talk a little bit about what BA2 is. So first, let me talk to one of our infectious disease guys here. Scripture, what's BA2? Stealth variant, what do you got?
It's very similar to the Omicron. It's, I would say, like a brother. It's got some slightly different mutation profiles that seems to mean that it would somehow slip past immunity acquired from Omicron. I don't know that that's entirely true. I went back and looked at countries that had higher numbers, like India, and I think it was Denmark. And it doesn't seem to be that there was any worsening of cases as that variant came in and took over for Omicron, or whatever was circulating at the time. So I can't say that I'm concerned. I think there's quite a bit of cross-reactive immunity, and the vaccines seem to work against it. So I should knock on some wood at some point, but I myself am not concerned about this variant.
So Hawkeye, that's what I'm reading too, is it looks like it's going to be handled by the vaccine, by prior immunity or whatever, and not going to be that different. It may be a little more transmissible, or you may be a little more communicable, but doesn't look like it's going to cause more than what Omicron has.
Yeah, I would agree. Again, what we do know, the best available data right now is for that T-cell immunity, meaning that best immunity to protect you from hospitalization, severe disease, and death, which is most safely garnered by vaccination. We know that T-cell immunity, the vast majority of that T-cell immunity, continues to be active even against Omicron. We know that the major issue with Omicron is probably just the change in the spike that makes it kind of hide from those antibodies that you have a little bit better than some of the other variants. And so really, I think that the changes in the spike with BA2 is really similar to the changes with the original Omicron. So overall, just what you're saying, don't expect it to be too much change as far as disease process, and you should have continued to have pretty good immunity, especially with vaccination.
Dr. Antonios, what are you thinking about? I mean, you study this so much, and I know in our conversations you've got a great handle on the epidemiology of this. What's your sense of what the future is going to hold around, whether it's the stealth variant or another variant? How does spring look to you?
That's a good question, and I want to agree with our infectious disease doctors. We can call it a brother, maybe it's a cousin of Omicron. It does have a few more mutations. And I've been trying to track some of the data on this. I still don't have any really reliable information. We don't have any evidence that it will cause a profile different than Omicron in general right now. Obviously, things could change. More research is published every day about this. As you're aware, we try to keep up with what gets published. But as it stands, it doesn't seem like it is clinically all that different from Omicron, and time will tell. However, going back to your question, there's a couple of things that are important to know. We will see future variants. Now, if I look at the Greek alphabet, I don't have mixed feelings about the next one. If they follow behind Omicron, it should be pi. Because I like the number pi, but I don't know if how I feel about the pi variant. But nonetheless, we know that future variants will occur. And what will be the defense of people? Our defense will depend on if we have had immunity in our bodies, which the safest way to get that immunity in our body is through the triple dose. Fully vaccinated along with a booster, that's how we can get our defenses ready. We know that there's some also immunity that comes from people who have been previously vaccinated, have been previously infected, but we also don't know how much is that going to last. And so the best way is to keep up with the vaccine regimen, including a booster. I'm a little bit disappointed when I look at the number of percentage of boosted individuals in our communities because it is lower than it probably needs to be. We know future variants are coming, so we need to be aware and protect ourselves from our waning immunity that will happen over time.
Yeah, I think that's right. And going back to some discussion too on this is when you look at the people in our hospital who are dying, it's almost entirely the unvaccinated patients. Now, there are some undervaccinated, I call undervaccinated people who haven't gotten their booster, who have passed away and may even make it into the ICU. But when it comes to deaths and ventilators, it's almost entirely, like 90% or more, unvaccinated. And that continues even until this day. Jess, other questions?
So Tanya wants to know, there are many speculations about Omicron being the end of the pandemic, even some countries lifting all restrictions. Tanya just wants to know what our panel thinks about that, and is that the right thing to do?
Dr. Steele, what is your sense of that at University Health? Do you see Omicron as being the end of the pandemic? Because if it is, I'm going to high-five you across this screen.
Yeah, I mean, I have a little bit of concern about that. I mean, it seems a little premature to me to be lifting all these restrictions. And I think something that should give us all pause is what is going on in Great Britain, because that sort of has forecasted what we see here in the US. And in Great Britain, the cases were plummeting. And then for the last several weeks, they've sort of plateaued a little bit. And so it has, and it's still, their numbers are still well above their prior surges, and they're a pretty heavily vaccinated country. So in terms of predicting, I mean, it's hard to predict this, but I certainly hope the spring and summer is a lot better, and I'd like it to be like last spring and summer, but I think we can't be assured of that by any stretch.
Yeah, the numbers in Britain have disappointed me a little bit because I really thought we were going in for a little better news, but as that news keeps developing, the kind of ongoing transmission, mostly in unvaccinated people, even in Britain, is still a concern. And Dr. Freelove in Salina, how is the vaccination going?
Well, it's a steady crawl is, I guess, is how I would describe it. Unfortunately, we have had some people here with Omicron and the recent surge. We have had some people take up vaccine anew, and we're seeing more boosters. But we really slowed down quite some time ago, and like I said, it's been kind of a steady crawl since then, which is unfortunate given what we know about vaccines, the safety, the efficacy, the immunity that it provides. We're still seeing the majority of our inpatients are unvaccinated or only partially vaccinated, and certainly those who are fully vaccinated or who are vaccinated who get hospitalized, they tend to not have that booster. So I wish I could say that it was 70 or 80% was a number that I'd love to see, but we're still hovering in the low to mid 50%, which could be worse, I guess, but certainly could be a lot better.
Yeah, and I think that hence becomes the problem, is there becomes this reservoir of folks who aren't vaccinated who are still going to share the disease and get sick from it. It's going to keep us a little busier. So, Jess?
Vicki is a reporter with KCUR. She has a question for some of the CMOs. Just asking about the metro hospitals, what they did during the surge, and about the adequacy of healthcare infrastructure as well as crisis standards.
Okay, Dr. Stewart. Let's tackle that one here in our metro. What do you think?
Well, everybody's been stretched. Here, almost 2 years ago, we opened a unit that was unused, so we added 40 beds, and that became our COVID unit. And during this last surge, we had to change some of our med-surg units to COVID units as well. But I think that early on, the problem we were concerned about PPE and keeping everybody safe. And I think over the last 2 years, we've figured out how to do COVID, but the challenge is to figure out how to do COVID when there are other sick people out there, that people having heart attacks, people having strokes, and we need to be available for all those sick people, not just the COVID patients. So when the numbers go up, it gets difficult, but I think that we need to stay open and we need to take care of all of our community with all of the problems, not just COVID.
Yes, and Dr. Hayes, thoughts about that? Because you've also talked about the effect on our mental health before.
Yes, I would say that that's probably one of our big take homes is that when you lay a pandemic on top of a staffing shortage, you're bound to have mental health issues develop. And we've developed team member well-being calls that happen regularly. We have an employed psychologist for our medical staff, as well as a licensed social worker for our team members. So that's how we've dealt with that part of the crisis. But we know that it's going to be an ongoing, the mental health issues are going to become endemic, just like the COVID virus will become endemic as well.
You know, I think that this is all exactly right. And just to say, the undescribed effects are so important here. When we look at healthcare infrastructure, here's a story. So I talked about this a little bit yesterday. I was on inpatient rounds last week, and I do a lot of CF, cystic fibrosis care. So we have a cystic ward devoted to CF patients. That became a COVID ward. So the nursing staff who we've trained in cystic fibrosis are taking care now of the COVID patients. My patients were to a different unit, went to the peds unit. They did a great job. It's not the same as being down on the adult unit because we also do a lot of lung transplant, and we have to wrestle with the drug levels and follow up from our transplant patients. And so when they're up on the peds floor, the nurses there don't have that level of experience, and they are great people. They are a great team, and they kept saying, "What can we do better? What can we do better?" They all want to help and pitch in and get there. The challenge is, though, in every story, when you displace patients from the unit where they're supposed to be, because you've got all these COVID folks those patients are now going somewhere else. And sometimes you can centralize them like we were able to do. Sometimes you can't. And so then the patients may not have the same experience as they would have normally because you've got so many COVID patients displacing how you do your care. And they say, well, let's just redesign our hospital. Let's take care of COVID. And we've done that. I think all our teams have done that. The challenge is if you have 50 COVID patients or if you have 250 COVID patients, which is generally was our range here, that's a completely different story. And so that flexing up, flexing down, flexing up, flexing down becomes a huge challenge. There's just no other disease like that. And so the toll on your staff, the toll on the mental health, and the toll on every other patient you see. Because when you can't get the same level of care to everyone that you expect to do, those patients, they're not going to do as well. You could do your very, very best, but some days that makes it really hard. And so, Dr. Dishman, I got to believe at Stormont, you guys are big, you have a big hospital, you've got to be seeing the same thing.
Very much so, Steve. And again, I have to echo your sentiments. I mean, staff do absolutely everything they can and to work the problem, work the issue, and deal with that patient that they find in front of them. But as a system, it's very challenging to ensure that you're providing the utmost in high quality, high performing, and safe care. And we're all dealing with that right now. We're all learning how to operate outside of our normal processes. And I think that's going to be a learning experience that we take into the future, just like many of the other things that we've talked about. If there are any bright spots in this pandemic, it's the ability to have flexible staff and the ability of physicians and nursing staff and our ancillary staff to work closer together to address these challenges. So we're all seeing that, Steve. We're all dealing with it. And as Dr. Hayes appropriately says, it's all taking a toll.
Yeah, trying to get through this, just to be clear, COVID better is not normal. And for the patients in the hospitals you see on this call and throughout our region, this is not normal. So, Jess.
Joe from the Kansas City Star has a question. With cases going down, can people let their guard down just a little bit? What kind of concerns does that bring to?
Yeah, Dr. Highland, should people be letting their guard down?
Trying to get off mute here. Well, I think that's a good question. I think that individuals still need to be very careful. I think that if individuals are vaccinated and boosted, and if they're with other individuals who are vaccinated and boosted, and I think that then you can let your guard down. I think if you have relatives or friends who are immunocompromised, or if you work in a facility where you work with immunocompromised individuals, I think you need to be very careful. So I think it depends on the situation where you can let your guard down, but continue to be very careful. And as Dr. Site says, practice good infection control measures.
Yeah, those rules, they still follow you everywhere you go, Hawkeye.
Yeah, absolutely they do. And I think everybody needs to be careful. I think you should be offered some concessions and the ability to do things if you are vaccinated, if you are boosted, if you are up to date on those vaccinations. We know that will protect you. I think you still have to be concerned and use your judgment and take into account the risks and the benefits of what you do. But as the cases are dropping, as hospitalizations are dropping, and if you are fully vaccinated and boosted, you should start to be able to think about doing those things like you were doing when the cases were not as high as they were before this surge, before the Delta surge, and that's been a long time now. But I think you should be afforded some of those, being able to do some of those things. But again, it is still out there. We know it can still cause severe disease. You have to take those risks and benefits into account. And if you are in those high-risk situations, such as being indoors and in gatherings, then it is extremely important to continue to do those important things, such as masking and distancing as much as possible. But I think if you can protect yourself and your bubble as much as possible and understand those protective measures, eventually, and as the weather hopefully will get warmer. I know we're still in the middle of February, but hopefully we'll get a little bit warmer. We can be doing those things outside, which should be more important as well.
Jess.
Rebecca wants to know if the hospitals can update us on where they are with the monoclonal antibody supply. Are they getting any more?
Well, we've gotten a little more, so we have some, so that's been good. We still administer it almost as fast as we get it. So let me just turn to some folks. Dr. Harris, are you all doing much sotrovimab in Hayes?
Yeah, we did it a lot the last several weeks for those high-risk patients. And we initially had a little bit of supply issue, but now we've got plenty of supply. And so right now we're sitting pretty good with the medication. I also got a notice that I don't know if they have any left, but Walmart was starting to receive a little bit of some of the oral agents, but I doubt that will last very long. But right now we're sitting okay with the monoclonals out here.
Great.
That has improved.
And so let me just flip over to Missouri, and Dr. Steele or Dr. Stewart, how is the supply of sotrovimab? Because I know that we distribute it differently, both Paxlovid and orals, as well as the monoclonals in the two states.
Yeah, I could talk about here at University Health. We do have some sotrovimab. We have been administering it. We are getting small allocations. We certainly are not giving it to the same degree as when we were using the other agents for Regeneron and the one from Eli Lilly, but we do have it and certainly would like to have more of it.
Dr. Stewart, same story or anything about Paxlovid?
The orals are hard to come by. We are giving the monoclonals, and the supply is limited, but we give what we can, and we're still doing that, yeah.
And Dr. Petrash, the VA, for our veterans, you all have had a great program for distribution of monoclonal antibody.
Yeah, we received, of course, it was limited supply in the beginning. I believe we do have some supplies now that we can prescribe. The Paxlovid has some drug-drug interactions that has been kind of like limiting its use in some patients, and some of our patients are really complex. But in general, as long as we get notified like within 5 days of symptoms, and those patients, sorry, I need to clear my throat.
We'll get you a COVID test.
I know. That's what I'm going next. But yeah, so some of these patients are, if we know about them within 5 days of start of symptoms, they would qualify for the PO if they are high risk. And we are doing some sotrovimab as well within 10 days of the start of symptoms as well. So yes.
All right. Jess.
Did Dr. Hayes have her hand up? I just wanted to make sure we got to her.
Yes, I did. I was going to say,
I missed
just
it.
got an
Thank
update.
you.
Thank you. I just got an update from our pharmacist. Yesterday, we had 18 doses of the sotrovimab in stock, and today we have received another 12. But on average, we're giving out 4 to 8 infusions a day of that. So our supply is certainly limited. We would love to have access to more. We've also received a shipment of Evusheld, an allocation from the state, and are operationalizing that through our cancer center for our severely immune compromised individuals, and hoping to be able to expand that to other immunized compromised individuals. And then also still having limitations in access to the oral antiviral medications as well. So supply issues continue to be an issue.
All right. Jess, thank you.
Okay, so yes, Jonathan doesn't feel that asking the general public to bend the curve is a winning strategy with new variants possibly coming down the road. So he's curious what changes the hospitals are making to prepare for another possible surge if we can't rely on the community.
Oh, that's a great
Which I think
question.
you think we can. We can, but.
Well, we can. So we have to, as we are in it together. But let's start. Dr. Alexander, what's your sense with Centura St. Catherine? What are you guys doing in a smaller hospital, smaller town? How do you do it if you can't get folks to help you bend the curve? What's a hospital do? Yeah, I gave you the hardest question of the day. Yeah, that is a hard question.
Appreciate that. Yeah, last on the list and hardest question of the day. So we just try to continue to push the information out there to the public of what's actually the science, what has to happen, other than just education. I mean, you can't force them to do it, but I have a concern about this little glitch where Omicron wasn't, quote, as bad, end quote, as Delta. Who knows what's next after Delta? We'll have another Delta. That's my concern, and we just have to educate the communities that that's where it's going to be.
I think one thing we're doing, and I'd be curious to see what someone else thinks, that I think that hospitals have had to adapt in terms of their nimblability, that how nimble we are. I just made up a new word. Sorry about that. I butcher the English language on a regular basis. But how nimble we are in responding to these shifts. Because when you have 5 COVID patients and weeks later you can have 105 COVID patients, that's such a difference. And what we have to do is get used to opening ORs, closing ORs, opening clinics, closing clinics, opening beds, closing beds, turning on the transfer center, turning off the transfer center. The people who suffer from that are our own staff. But it's the public, right? So you're right. I think that the author of that question is asking a great question. Actually, we do need the public, though. I'm going to disagree. We do need the public to help us bend the curve. And if people in public can adapt the same degree of nimbleness, so when things get better, then sure, take masks off more often, get into public, go do stuff. When things get bad and the hospital starts saying, we can't take care of you, you got to help take care of us, right? You've got to help take care of us. Dr. Antonios.
So I think the word you were looking for is nimbleness. And I agree. It's a great word, and it's hard sometimes for hospitals to be able to achieve that nimbleness. Every community needs its hospital. The hospital in every community we have in our state and across the country is the infrastructure that people rely on if they have a broken arm, if they need to go and deliver a baby, if they need to go and seek care. And so every community has a vested interest in making sure its hospital, as its infrastructure, just like all the other infrastructures, is healthy and thriving. And today, there are 2 things that I would actually encourage people to do. And one of them is that we need the community to understand that we need more investments in the workforce that works in those infrastructure. Anything that can be supportive of education programs, and other support programs that would increase the workforce is needed. And number 2 is a lot cheaper, doesn't cost anything, and that is kindness to that infrastructure. And those 2 would go a long way in making sure that the hospitals are resilient to be there for their communities.
Yeah, I love what you just said about that. That point about kindness is spot on. Dr. Batrash.
Yeah, I agree. I think this is a problem of building infrastructure takes time. So to say that if the community cannot bend the curve, that is a big problem because that takes us time. It takes us time to train healthcare workers, to get more of them, to hire more of them, and open more beds and create more beds. So all these kind of things, any hospital system can consider doing if there is a consistent demand that is going to increase the number of beds needed for patients to take care of on a day-to-day basis. And this is something we're all considering, I'm sure. But to do this in a short amount of time, it is just impossible. And it creates a lot of burden on any healthcare system, and especially when it's across the U.S. So you cannot borrow from other areas to help you here. In the past, like when New York started to have the first surge, people helped New York City. They went, they helped staff the hospitals and stuff like that. Right now, you can't ask other states to help you. It's just not available. Everyone is struggling the same way. So that's really a big problem for us. And we are still in contingency staffing also right now. So for us to say, we cannot maintain this contingency staffing, which means nurses are taking care of a higher number of patients than they used to. We cannot maintain this for a long time. This is not something that is safe for patients for a long time.
All right, then we're going to go to Dr. Hyland, Dr. Steele, then we'll have some closing comments. Dr. Hyland.
Just in response to, what can the hospitals do if the community is not able to respond to help in a pandemic type of a situation. The hospital is part of the community. It's here in Topeka and Shawnee County. The hospitals are the largest employers here in Shawnee County. The individuals that work within the hospital have, children in school, children in daycare. So they're affected in the community if people don't want to be vaccinated or are spreading the virus. The supply chain, which is supported by the community, affects the care that you can get in the hospital. So it's a closed system, and the hospitals cannot be healthy without a healthy community. So,
yeah, I think that's so right. Dr. Steele.
Yeah, I was just going to tag on to what you were talking about, Stephen, that I think that historically hospitals have not been particularly nimble, but with the pandemic, we've been forced to be nimble right from the get-go and out of the gate. And many of us had to set up very large drive-through testing operations and vaccination clinics. And we literally did that within days or even a day sometime. And I think, unfortunately, we've had more practice at this than we would have preferred. I think we certainly thought after last winter's surge that that was the worst that we were going to see. And unfortunately, along came Delta and then Omicron, where I think none of us really imagined that we were going to see the spike in cases and the number of deaths that we currently are seeing.
All right. Thank you, guys. First of all, let me just say thanks to all of our CMOs and everybody across the region, even those who are not here today, because we have a terrific group of people. And the group of people here today have just done an outstanding job at describing COVID better. We are clearly not COVID good. One of the things we can ask of our community is this. We've said, keep your mind open, right? Keep your mind open to faith, hope, and science, because we know ultimately that will keep us all safe and strong. And be a critical thinker about the information you get, and make sure you don't get it just from the internet. The folks on this conference and this call, these are honest, good people trying to tell the truth about the real experience in their hospitals and health systems across our region. This is the truth that we face. It's not the stuff that you may read or hear from people with vested interest or folks who have all different agendas. We have one agenda, and that agenda is to try and keep you safe. So keep your mind open, but also, to the last comment, keep your ears open, because you've got to hear our pleas for help when we need them. We can't do it alone, and the people who pay the price are not just the COVID patients, it's everyone. And until we get to the point where we can really take care of a crisis of this magnitude, we need us all to realize we have to keep our mind open, we have to keep our ears open, so we can keep our society open. Tomorrow, it's all things vaccine with our expert, Dr. Kevin Ault. He's not only an OBGYN here at the health system, he's on the Advisory Committee on Immunization Practices of the CDC. He'll tell us where things stand on vaccines for kids and when we might see Novavax, which is getting approval overseas here in the U.S. We heard earlier that the intensive care units are still full of COVID patients. That puts a stress on the whole system because they are there usually 3 times longer than most ICU patients. Casey Pickering is the nurse manager in one of our COVID ICU units. And as we leave you today, we want you to hear in Casey's own words what life is like in these days in a COVID ICU. We'll see you tomorrow at 8. Open minds, open ears. Thank you.
All right, everybody ready? Yep. 1, 2, 3. All right, ready? 1, 2, 3.
People always want to ask the question, what do you wish you could say to people? There's nothing left to say. The people that were going to hear it have already heard it. They've gotten vaccinated. They're wearing masks. They're doing their part. And those that haven't done their part, they're not listening.
Yep. 1, 2, 3.
The vast majority of the people that were taken care of, it was preventable. Like, they don't have to be here. The thing that's hard is that people don't understand that they don't realize until it's actually their loved one, right? Until it's their loved one who's in a car accident and they can't get here, but they need to get here, but they can't get here because there are no beds. And why are there no beds? Well, we have 203 COVID patients today. By the time they actually pay attention and decide that it matters to them, it's too late. Lots of people they're tired of it, they're sick of hearing about it, right? Nobody's more tired of it than we are, but we're still here and we're doing it every day. If folks would actually just pay attention and really take a hard look at what's happening in their communities and the way that it's impacting our healthcare providers, but our healthcare systems as a whole. This is my heart and my soul. I've been here for almost 17 years and I've never imagined doing anything else, and I can't imagine doing anything else. We come back because of the people that we get to do this with. We come back because it's our passion. We come back because we want to help people, right? And we want to take care of really sick patients. I just hope that, people go back to trusting healthcare providers the way that they used to. You rely on us for everything else, and you trust us for everything else. I hope and I wish that people would trust us for this and listen to what we're saying and asking people to do. Just don't forget about us because we're still here, and I think it feels often like people have forgotten that we're still here.